be a very quick lecture on cardiovascular disorders. And the reason that it's going to be really quick is we're not going to discuss all of the congenital heart defects because I've posted all of the Khan Academy videos for you guys in Canvas discussing each specific defect. So I'm not going to go into those because you've already got that information. So when we are looking at cardiovascular disorders, most of these are going to be due to congenital heart disease. These are the leading cause of morbidity and mortality in the first year of life, and many are discovered during the fetal ultrasounds or early in the postnatal period. So anatomy and physiology, um, you have to remember with your fetal circulation, they're getting their oxygenation from the placenta and not the lungs, and their pulmonary vascular resistance is high and their systemic vascular resistance is low. So the foramen ovale permits a portion of blood to flow from the right atrium to the left atrium, and a patent ductus arteriosus, or PDA, provides a connection between the pulmonary artery and the aorta, and that allows blood to bypass the fetal lungs because they're not breathing, um, on their own yet. So with your fetal circulation, you have two parallel circuits. You have your left ventricle, and that's providing blood to your upper extremities, and your right ventricle that provides blood to your lower extremities, and this is in the fetal circulation. So this picture is still kind of hard to see, and I will upload a full version of this, and I think it's actually in your book. Okay, so what's in your book is on page 757, figure 31-1, and that's the fetal circulation. So I will have to post this full-size graphic to Canvas for you guys to see the difference in the changes that occur between the fetus and the newborn. But in your neonatal circulation, once we clamp that umbilical cord, that increases the systemic vascular resistance because we're cutting off that blood flow from the placenta. That first breath is going to lower the pulmonary vascular resistance, and that's going to result in increased oxygen saturation. Once that occurs, then we have the closure of the foramen ovale, and the ductus arteriosus should close as well. Sometimes, however, those don't happen. Complete closure of the foramen ovale and ductus are gradual, and so we may hear transient murmurs for usually we shouldn't hear that for more than a couple of days. Persistent fetal shunts may cause a murmur and cyanosis, and so if for some reason they have a PFO or a PDA and it doesn't close, then we're usually going to hear a murmur and see some sort of signs of cyanosis. And it may honestly be a little while before anyone diagnoses this because, for instance, my youngest was probably close to 2 months old. Yeah, she was about a month and a half, 2 months old, and I brought it up to the pediatrician that anytime I laid her down to change her diaper, she would basically have some cyanosis around her mouth and increased cap refill. Cap refill was well over 5 seconds. And so they finally really listened. And I mean, this had been at least 3 pediatricians had seen her since she was born, and she did have, a little bit of difficulty at birth and required some oxygen. But we had 3 pediatricians that had seen her during that time, and nobody had caught on to the murmur until I mentioned the cyanosis. And they did that, and she had the PFO and the small ASD. And so it's a lot of times it's not as simple as these newborns are going to come in and you're going to hear this major murmur. Um, that you're just going to be like, wow, okay, yeah, there's something wrong with this kid. You have to listen to the parents. You have to pick up on those small things that when you lay the baby down to do the assessment, are they having color changes? Are you actually checking the cap refill on these kids? Um, so just keep that in mind, because it is important that we diagnose these, because we need to make sure that they close, because later in life, if they have these open defects and they've not been diagnosed, then it can lead to formations of clots and stroke. So we need to make sure that we're doing our best physical assessments on all of our patients, but especially on these newborns. History, we're going to do a review of family, maternal, fetal, neonatal, and infant history. We're going to always look at growth and development. We want to see a nice growth curve. And box 31-1 in your book talks about risk factors suggestive of congenital heart disease. So it breaks it down by perinatal, neonatal, newborn, toddler and school age, and family history risk factors. And that's on page 758. Physical exam, we're going to look at our vital signs. We're going to do our heart rate based on auscultation for a full minute. Pulses, we're going to compare our upper and lower extremities, because if we have bounding pulses in the upper extremities and weak pulses in the lower extremities, we may be looking at something like coarctation of the aorta. Blood pressure, we're going to do that at their well checks once they're about 3 years old and up. Respiratory rate, we're going to look at the rate, effort, and listen to the breath sounds. And we're going to check oxygen saturation, because we want to make sure that they are circulating enough blood to perfuse their body appropriately. Another thing in our babies, if we're concerned about possible coarc, checking blood pressure in both the upper extremities and the lower extremities. Physical exam, we're looking at their general appearance. Do they have any unusual facial characteristics? Because those, many times we have a child that has a heart defect, they may also have some unusual facial characteristics, because many times it may be part of a syndrome. We're going to look at their overall skin color. Are they having any respiratory distress, any peripheral or periorbital edema, and their height and weight on standardized charts. Palpation, we want to palpate all 5 areas of the chest. We're going to look at the precordial activity. So are we seeing any pulsations, lifts, heaves, or thrills? We're going to check peripheral pulses, and we're going to check the liver and spleen for hepatosplenomegaly. Auscultation of the heart sounds, and I think this is what gets us. It needs to be in a quiet environment. We need to make sure we are really, really listening. And we're going to listen for S1, S2, S3, and S4. And this just kind of breaks down what you're going to hear. S1 is at the beginning of systole. That's that closure of the AV valve, and that's often a single sound. S2 is going to be your aortic and pulmonic components, and that's going to mark the end of systole. In children, though, if they take a breath in, sometimes that S2 will split, and that can be a normal variation. S3 is going to be associated with rapid ventricular filling, and we may hear that in a quiet infant or with a rapid heart rate. So that's when we hear that gallop rhythm. Then S4 is always pathologic. This is because there's increased force of atrial contraction and ventricular distension. Murmurs, up to 80% of children have innocent or functional murmurs. In table 31-5 on page, let's see here. Table 31-5 on page 766 talks about the common innocent murmurs, and so it will give you a description, the age when you usually see them, where you will usually hear it, the quality, intensity, and then the differential diagnosis associated with that as well. All murmurs intensify by factors increase in cardiac output. So if we have a child that's anemic, if they have a fever, if they've been exercising, anything that's going to increase that cardiac output is going to cause a murmur to be louder. Significant defects may not have murmurs, and we would want to use the criterion table 31-4, and that is on page 763 to describe the heart murmur. So we want to look at the grade or intensity. So, how well can we hear it? The timing in the cardiac cycle, is it systolic, diastolic, is it continuous? The location on the chest, so, are we hearing it at the aortic area? Are we hearing it at the left lower sternal border? Are we hearing it at the apex? Is it radiating or transmitting to the back or to the carotids? What's the quality? Is it musical? Is it harsh? The duration and the pitch. So we would use all of those criteria to describe our murmurs. Common diagnostic studies, we would want to do possibly a chest radiograph. Usually if we hear a murmur, we're going to go ahead and do an electrocardiogram and an echo. We're going to do a CBC. In some cases, they may require cardiac catheterization, especially if we're concerned about occlusions. Hyperoxia tests, MRIs, and exercise testing in some cases. Primary healthcare management strategies, we want to make sure that they're getting adequate nutrition for optimal growth. Optimal psychosocial development, preventative vaccines, because again, if they're sick, that's going to put that much more strain on their cardiovascular system. We want to prevent any avoidable complications, prevent infective endocarditis. Again, we want them to have optimal fitness and optimal neurodevelopmental adaptation. We're going to refer them to a pediatric cardiologist if we suspect any cardiac disease. If they have an oxygen saturation lower than 95%, any symptoms of CHF, a pathologic murmur, so that's one, or if they have one that's difficult to differentiate if it's pathologic or not. Other murmurs are going to be referred non-emergently. Infants with changes in breathing, increased irritability, and poor feeding, or cyanosis, we're definitely going to get those over to the cardiologist, usually same day. Older children with dizziness, chest pain with exertion, arrhythmia, dyspnea, syncope, CHF, or abnormal vital signs. Genetic testing, we want to refer if there are other congenital anomalies present. So again, if they have those dysmorphic features, neurocognitive deficits, growth retardation, if we have a mom that's had multiple miscarriages and now we have a child with possible cardiac defect, then we want to get them checked for genetic, or we want to send them for genetic testing. And if they have siblings with congenital defects, again, we want to do some genetic testing because we may be looking at a hereditary disorder. Family support, we want to understand the diagnosis and help them cope with the consequences. We want to advocate for the family because this is going to be usually a lifelong process. We want to teach them about the disease, the management and complications, and we definitely want to get these families some CPR training. Congenital heart disease, as far as general information, these are going to be caused by an alteration in the development of or failure of the embryonic heart to progress. Usually these are going to occur in the 2nd to 8th week of gestation, so that's why we will usually check more thoroughly at that 20-week anatomy scan, because by then we would usually be able to see pretty well. 2 to 4% of these are going to be caused by teratogens, so lithium, retinoic acid, anti-epileptics, ibuprofen and naproxen, ACE inhibitors, tricyclic antidepressants. So, any teratogen, that's usually heart and brain development are the biggest things that we're worried about with the teratogens. specific congenital heart disorders, again, I'm not going to go into these because you do have the Khan Academy videos for all of these, and you've had those all week. So to help with the length of this lecture, I'm not going to go into these specifically. I will load this slide deck up for you because it does have the pictures of the specific heart defects along with the information. And this information will be on exam 3. So I don't know if I included a Khan Academy video on congestive heart failure. So I will discuss this one really quick. This is a progressive syndrome in box 31-4 on page 770 in your book. Talks about the signs and symptoms of CHF in infants and then children and teens, because what we may see would be different based on age group. These may be caused by malformations leading to volume overload or pressure overload. The largest group that we're going to see have excessive left to right shunting. The use of neurohormonal agents is complex in children, and traditional therapies like diuretics, inotropes, afterload reducers are still used in many cases, even in the pediatric population. So your left to right shunting congenital heart disease, I'm just going to kind of skip over these slides, but the way that I have this broken down is your left to right shunting, and I have it broken down by your acyanotic, your cyanotic, and so you'll need to keep that in mind for the exam. So this is your picture of your ASD. And your VSD. Your atrioventricular septal defect. Your PDA. And this is where when we go to our cyanotic defects. So your transposition of great arteries. Tetralogy of Fallot. Tricuspid atresia is the picture that is at the bottom right, and the hypoplastic left heart syndrome is the picture that is at the top left, or at the top right, I'm sorry. Obstructive cardiac lesions. We would have our aortic stenosis and insufficiency. Pulmonic stenosis. Coarctation of the aorta. And then long-term complications associated with congenital heart defects when we're transitioning to adult care. About 90% of these kids do live to adulthood, but they do require many surgeries. They may be palliative or incompletely corrective. Many lost follow-up as adults. Late adolescents should be transitioned. Um, so again, as I've said many times before, just for adolescents in general, when they're in their mid to late teen years, we need to be teaching them to prepare to manage their own health, and health care. Left-sided lesions, we worry about significant stenosis and regurg that may occur. They're going to possibly have exercise intolerance, dyspnea, arrhythmias, sudden death, endocarditis, syncope, and angina. Left to right shunt lesions, these may have elevated pulmonary vascular resistance, Eisenmenger syndrome, arrhythmias, dyspnea, deterioration of the left ventricular function, and left ventricular dilatation. If they have chronic cyanosis, they can have chronic hypoxia to organs, hyperviscosity, and hematologic problems. They have valvular problems. They may have mitral valve prolapse, mitral regurg, arrhythmias, and sudden death. If they have ventricular failure, they can have prolonged aortic pulmonic valvular stenosis or regurg, chronic cyanosis, myocardial ischemia, poor ventricular compliance, arrhythmias, and they may need a heart transplant. With arrhythmias and heart blocks, they have a risk of sudden cardiac death, rhythm disturbances, and their management is going to be complex. So sudden cardiac death, and we want to screen for causes of sudden cardiac death when we do those sports physicals. And also if we have a child that complains of chest pain, syncope, or palpitations. Most common causes are not easily diagnosed by the history or exam, and the most frequent cause of exercise-related sudden cardiac death is cardiomyopathy. Other congenital causes for sudden cardiac death, we may see coronary artery anomalies, aortic dissection or ruptures, like for those patients with Marfan syndrome, and I think we talked about that a couple of weeks ago, mitral valve prolapse and aortic stenosis. We may also see congenital electrical abnormalities, so WPW, long QT syndromes, Brugada syndrome. Acquired causes, commotio cordis from blunt trauma, myocarditis, performance-enhancing drugs, premature coronary artery disease. Clinical findings, we'll usually find that there's some sort of hypertrophic or arrhythmogenic right ventricular cardiomyopathy, and what we'll usually see is that there was some history of syncope and a family history. With hypertrophic cardiomyopathy, they'll usually have a dynamic murmur, and we'll also usually see that they've had some arrhythmias and shortness of breath in the past. Diagnostic studies, if it's a hypertrophic cardiomyopathy, we're going to see an abnormal ECG, severe LVH on echo, attenuated blood pressure response to exercise, with an arrhythmogenic right ventricular cardiomyopathy, we would have changes in a resting ECG and on echo and MRI. Management, we want to refer all children with a family history of sudden cardiac death, inheritable cardiomyopathies, Marfan syndrome, chest pain concerns, acquired or congenital heart disease, cardiac rhythm disturbances, and palpitations. Box 13-5, so chapter 13 talks about the cardiovascular screening checklist. Okay, I double checked that. It should actually be box 13-3. It's the 14-element cardiovascular screening checklist for congenital and genetic heart disease. And it's on page 251. And so it looks at personal history, family history, and then what we see on physical examination. So page 251, box 13-3 is your cardiovascular screening checklist. Acquired heart disease. So chest pain in pediatrics is a common complaint and it's rarely serious, and many times it's because the child doesn't really know what the pain is that they're feeling, and they can feel some pain in their chest, but um, it's not actually a cardiac um, related pain. It should actually be table 31-9 is the cardiac causes of chest pain and associated findings for pediatric patients. That's on page 782 in your book. And it lists all of the possible cardiac causes. The most common cause of chest pain in children is musculoskeletal in origin, and it's usually going to be like costochondritis. So it's usually that they've pulled a muscle in their chest wall. Chronic chest pain is usually psychogenic, and chest pain with a cardiac cause is usually going to be consistent over time. Clinical findings on the history, we may see a past medical or family history of sudden death, heart disease, asthma, Marfan syndrome, um, past sports and events, previous trauma or muscle strains, and we want to ask about the characteristics of the chest pain. Is it in relation to exercise? Have they had any syncope or dyspnea? Any burning or substernal pain, sharp stabbing, pain that awakens the patient, or any other associated symptoms? On physical examination, we'll usually hear a cardiac murmur. We may hear some rubs and clicks. They may have point tenderness at one or more costochondral joints, irregular heart rhythm, shortness of breath, coughing, wheezing, rales, wheezing, and tachypnea. Diagnostic studies, if they're febrile, if we suspect pulmonary or cardiac conditions, we're going to do a chest x-ray. If we think that it is exercise-induced asthma, we're going to do a pulmonary function test. If it's a rhythmic disturbance, we would want to do a Holter monitor and stress test. If they have any signs of congenital heart disease, pericarditis, or myocarditis, we'd want to do an ECG. Differential diagnosis, we want to rule out costochondritis, TC syndrome, idiopathic pain, precordial catch syndrome, or other musculoskeletal causes. We also want to consider esophagitis, foreign body ingestion, or exercise-induced bronchospasm. Management, we want to reassure after all of the serious causes have been ruled out, and we would refer them to pediatric cardiology if they have any chest pain that worsens with exercise, any that suggests angina, positive findings on examination, ECG or chest x-ray, or any concerning personal or family history. Hypertension, we are starting to see more in the pediatric population, and this would be when their systolic or diastolic or both are greater than the 95th percentile. If we want to diagnose them with hypertension, we have to make sure that we have taken their blood pressure on at least 3 separate occasions, and usually we will have them come in at different times of the day for those measurements as well. This breaks it down by what is considered high normal is your prehypertensive stage 1, stage 2. I would definitely be able to recognize those stages. There is an increasing risk related to obesity, and secondary hypertension usually is going to occur under the age of 6. Clinical findings on the history, we need to assess whether this is a primary or secondary hypertension. Neonatal history of prolonged mechanical ventilation, prematurity, that's going to put them at increased risk for hypertension. If they've had any prior hospitalizations or trauma, we're going to look at their diet, activity, and smoke exposure, their sleep history, and if they have sleep apnea, any medications they may be on, chronic illnesses or history of UTI, headache, chest pain, dyspnea, muscle weakness, or palpitations, and family history of MI, stroke, hypertension, and other cardiac diseases. So this is from the National Heart, Lung, and Blood Institute, and this is guidelines for cardiovascular health and risk reduction in children and adolescents. And so basically this is just giving us the check blood pressure. We're going to measure their height, weight, and calculate their BMI, determine their blood pressure category based on their CDC growth charts. And then once we know their percentile, then we can determine their stage, and then how we're going to follow up, and then how we're going to treat. Clinical findings on the physical examination. We're going to look at their body habitus. So are they overweight? Do they maybe have some metabolic syndromes? Again, any dysmorphic features, because again, some of those congenital conditions can have hypertension as a symptom. Edema, pallor, flushing, skin lesions of tuberous sclerosis. We're worried about lupus, neurofibromatosis if they happen to have any cafe au lait spots. Upper and lower extremity central pulses, we're going to check. Funda, thyroid, abdominal masses, we're going to check for flanked bruits, visual acuity, and facial palsies. And again, we're going to look for elevated blood pressure. Diagnostic studies, we may do a lab evaluation if their blood pressure is high to check for any underlying causes. If they are under 10 years old with secondary hypertension, we're going to do a CBC, ESR, CRP, UAN culture, electrolytes, BUN, creatinine, plasma, renin, renal nuclear scans, and a renal ultrasound. If we suspect renal vascular disease, we're going to refer them to a pediatric nephrologist. And then we would do an echo if we suspect cardiac involvement. Management, we're going to do blood pressure annually on all children ages 3 and older. If they have pre-hypertension, we're going to do 2 follow-up blood pressures. If they have hypertension, if they're overweight, we're going to do treatment of obesity with lifestyle changes and refer them to a nephrologist if hypertension is persistent. Medication management, table 31-11. I think it's actually table 31-10. All of these tables seem to be off in this chapter. Table 31-10 talks about the antihypertensive medications for children and what class they're in, and initial dose, maximum dose, and dosing intervals. So that's on pages 787 and 788. Complications, we may see increased left ventricular mass, other heart changes and renal disease, and lifestyle changes should definitely be taught. So now we're going to talk about infective endocarditis, and this is a condition that's a bacterial or fungal infection that invades the endocardial surfaces of the heart. It is more severe in gingival inflammation, increased plaque, and there's more microbes in children that have subacute bacterial endocarditis. Clinical findings, history and physical exam, we'll see underlying structural abnormalities. We'll see that they've had a recent dental procedure or oral surgery. If it's acute, they'll have a high fever, myalgias, night sweats, arthralgias, headache, and general malaise. If it's subacute, they may have a low-grade fever, progressive, non-specific symptoms. So you can see in the picture the buildup of the bacteria or fungal infection there in the valves. Clinical findings on the history and physical examination, we may see embolization symptoms, so they may have hematuria, acute respiratory illness, splenomegaly, neurological changes that may be associated with stroke, petechiae, Janeway lesions, osseous nodes, Roth spots, and splinter hemorrhages. Diagnostic studies, we're going to base this on our clinical findings as well as blood cultures. We're going to do an ESR, CRP, and their white blood cells will be elevated in the acute stage. And we would do an echo for diagnostics. Differential diagnosis, we would be concerned about possibly postoperative fever, collagen vascular disease, or childhood cancers. For management for this, we're going to hospitalize the child and refer them to pediatric cardiology. We're going to treat them as soon as we suspect this. We're not going to wait. And they're going to have high doses of antibiotics for about 4 to 6 weeks. Complications, this does have a high morbidity mortality rate. It can result in destruction of the heart valves, disseminated sepsis, and septic and thrombotic emboli. So this is a very serious condition. Patient and family education, children with high-risk cardiac conditions, they're going to have prophylactic antibiotics as directed anytime that they are having any dental work or anything like that done. And we want them to maintain good oral hygiene. Myocarditis and cardiomyopathy. Myocarditis is rare in our pediatric population, so it may go unrecognized and resolve spontaneously. However, it may progress to cardiomyopathy, and that can result in death. It is often caused by viral infections or non-viral infections, medications, autoimmune or inflammatory disorders, or toxic reactions. Inflammation can cause dilation of all cardiac chambers, and those myofibers occur during healing. In the history, we will usually see that our infants have had a history of fever, irritability, pallor, diaphoresis, tachypnea, respiratory distress, and poor feeding. In children, we will often see that they have had a recent viral illness. They've been lethargic, had a low-grade fever, pallor, anorexia, have had some exercise intolerance, rashes, palpitations, and respiratory distress, and that's usually a late finding in children. Clinical findings on exam, they'll usually be pale. They may have some cyanosis and some cool mottled skin. They may have rapid labored respirations, tachycardia, a gallop rhythm, muffled heart sounds, a murmur, and weak peripheral pulses. And they may have hepatomegaly and jugular vein distension. Diagnostic studies, we're going to refer these children to pediatric cardiology if we even suspect this, and they will get a chest x-ray, ECG, echo, and other labs. Differential diagnosis, we want to rule out sepsis, asthma, recurrent vomiting, and chronic viral illness. Management for this is going to be supportive treatment, and it may take months, and they're going to have lifelong follow-up. Complications and prognosis, they may have pericardial effusion and scarring with persistent heart failure. Now we're going to talk a little bit about heart conduction disturbances. So cardiac arrhythmias can be primary or secondary. So if we have a sinus arrhythmia, that's going to be a variable heart rate, and it's going to increase with inspiration, and that can be a normal finding. Bradycardia is going to be your slow heart rate. You guys know this. It can be related to hypoxia, acidosis, increased intracranial pressure, abdominal distension, hypothermia, hypoglycemia, drugs, and increased vagal tone. If we have a child that has a complete AV block, that is usually, it can be congenital or acquired. Tachycardia, if we have a sinus tachycardia, they're usually going to have some predisposing factors that increase their cardiac output, so something like fever, anxiety, or infections. Supraventricular tachycardia is usually going to be pathologic. If they have a long QT syndrome, induced ventricular tachycardia, that is usually genetic. Premature atrial contraction, we may see that in adults and children, and PVCs are usually going to be benign. Clinical findings, we will see a slow or fast heart rate, and the rhythm can be irregular or regular, and we may see that long QT syndrome. Diagnostic studies, it's going to depend on the suspected cause, but usually we're going to do an ECG. Management of SVT, we're going to teach vagal maneuvers. We can do IV adenosine if we absolutely have to, synchronized cardioversion, And then long-term prevention, we can use beta blockers or ablation may be necessary. In long QT syndrome, we're going to refer them to the pediatric electrophysiologist. And obviously, even in our SVT patients, we're usually going to go ahead and refer them out as well. Our long QT syndrome, again, they're going to go out to the electrophysiologist. They're usually going to require beta blockers and possibly a defibrillator. Syncope, this is a transient loss of consciousness. Usually it's benign, but we do have to rule out all cardiovascular causes. In the history, we'll usually be able to identify some sort of triggering factors, and they've usually had prior episodes of syncope or fainting. We will often see that there's some sort of associated injury, especially in children. Tonic-clonic movements may indicate that they're having seizure activity instead of actual syncope. And they may also have vertigo, which can lead to syncope. Chest pain, palpitations, tachy or bradycardia, family history of syncope, possibility of pregnancy or use of drugs, exercise-induced bronchospasms, physiological stressors, and history of the event. Clinical findings on physical examination, we're going to do a detailed neurological exam and a cardiovascular exam, because when we have a patient with syncope, we want to rule out all of the neurological and cardiac causes. Diagnostic studies, we may see an abnormal ECG if it's a cardiac cause. We're going to do orthostatic vital signs because we're worried about maybe they're having an orthostatic drop in their blood pressure. We're going to check hemoglobin if we suspect anemia. Echo, again, if that history suspects that it's cardiac. And we may do treadmill testing for exercise-related syncope. Management, we're going to refer them to pediatric cardiologists if we suspect cardiac cause, and we want to try to prevent this with good hydration. Differential diagnosis, we want to rule out migraine, seizures, hypoglycemia, hysteria, hyperventilation, vertigo, CO poisoning, electrolyte imbalance, drugs, and cardiovascular disease. That wraps up chapter 31, cardiac. So if you guys have any questions, again, this is going to be on exam 3. Again, I didn't go super in depth on all of those congenital heart defects just because I've included those Khan Academy videos earlier, honestly earlier in the quarter, but they've been available to you for quite some time, so I didn't go into those because they do a really good job of explaining those. So definitely be familiar with all of your possible defects and what you would find clinically, and what complications they may cause. Be aware of murmurs and signs that maybe a child has an undiagnosed cardiac condition as well. So I will definitely be posting a study guide for exam 3, but I wanted to do these quick lectures as well. So I hope you guys have a great weekend, and I will see you all later. Bye.